series, session 7. And today it is a great honor for us to have Dr. Vibhavari Naik ma'am with us this evening. She is a senior consultant onco-anesthesiologist at Basvatarkam Indo-American Cancer Hospital and Research Institute, Hyderabad. She is widely reputed for her work in onco-anesthesia, pediatric anesthesia, and simulation training. Ma'am, as we all know, is an inspiring speaker, a passionate academician. She has delivered more than 200 lectures at national and international forums and contributed extensively to numerous publications and book chapters. At present, she is the clinical lead of World Federation of Society of Anesthesiologists. And today's topic selected by her, difficult vascular access from basics to advanced vascular devices, is highly relevant and highly useful for our daily clinical practice. And our esteemed moderators for today's evening, Dr. Ramana Prasad sir, Professor Gayatri Vidya Parishad Medical College, Dr. TDP Sublakshmi ma'am, Professor and Head of the Department, Government Medical College, Srikakulam, and Dr. Vijay sir, Head of the Department of Anesthesia, Omni Hospitals, Visakhapatnam. I'm sure the guidance and experience will further enrich this academic session. Also, thankful to all the delegates for joining us this evening and request them to actively participate and make this session interactive and academically rewarding. I now hand over the proceedings to the moderators for the evening.
Madam, welcome, madam. We are looking forward to an enlightening session from you. Over to you, madam. Please, you can start, madam.
At the outset, I just want to thank Dr. Veed Kumar for inviting me. I think we've been in touch earlier because we were planning some airway session and which did not work out, but I'm hoping that we are able to do that workshop soon. And thank you, Subbalakshmi Madam, Ramana Prasad Sir, and Dr. Vijay Kant for moderating the session. Today, I would want to cover a topic that is extremely close to my heart. I just want to check if the slide is visible and is in full screen.
Yes, ma'am.
Oh, okay, perfect. Right then. I bring greetings from Basavatarkam Indo-American Cancer Hospital and Research Institute. For those of you who don't know, this is a 600-bed standalone cancer institute in Hyderabad, and we do about 8,500 major cancer surgeries every year. Our department caters to onco-anesthesia, surgical critical care, pain, as well as palliative medicine. And we run onco-anesthesia fellowships as well as FNB in onco-anesthesia, and we also have DNB in palliative medicine. Okay, so now I think the most important question here is, why are we talking about vascular access? Vascular access is definitely important for all doctors and nurses, but it is the primary skill set for us as anesthesiologists. And often we are called as the vein specialists. When no one in the hospital can find a vein, they start looking at anesthesiologists. So we are considered masters in vascular access, particularly when it is difficult. And hence, each one of us, I feel, has to have the knowledge and the skills of anything and everything that's available for vascular access, right from basic devices, basic techniques to the advanced. And that's what we are planning to do here today. However, I feel that there are so many seniors in here. I would really like to listen from seniors because each one has their own, so I feel that the more we share, the more we learn. So please, I would really want to listen to your experiences once the session is over. I feel that vascular access is not just about knowledge, skill, science, but it's an art. It's an art to know when to do what beyond what the science tells. And let's try a few of those aspects today. Talking about difficult vascular access, the difficulty can be can be in a wide variety, can be very diverse. It can be because the skin is dark, because the patient is obese or there is edema. It can be because the skin is unhealthy. It can sometimes be also the patient is hypovolemic, which means the veins are perfectly fine. But because the patient is hypovolemic, you are unable to cannulate that patient. Sometimes it is unexpected and sometimes just wrong judgment. So let us try. So I'm going to videos, photos. I think most of my presentation is all about that. And I hope that it rings some bells and it helps you learn at least a few points you already know. Let's begin talking about the peripheral venous axis. Now, just to give you an example, say a 5-year-old girl is posted for some simple surgical procedure, and the child refuses IV cannula. Now, in my hospital is the practice. When children are posted for procedure, either we ask them and they agree to it. If they don't, we take them in for inhalational induction. So veins looked doable. It wasn't a difficult airway. So we took the child inside. And this is how we went about. Inhalational induction, typically the way it is done, putting 8% sevoflurane and getting the patient engaged on a video. I was recording this video on the phone while she was watching herself, and then she fell off to sleep. A busy Monday morning, I jumped up quickly to put in an IV cannula, my assistant helping me, but I failed. So what could be the causes? Now, I think there are some basic rules that I want, and most of this presentation is actually directed to postgraduates. So the seniors in there, please excuse me when I start talking about very basic things. So for the PGs, I wanted to say that children, when they have longer fasting intervals, these children can have veins collapsed. And as I mentioned earlier, hypovolemia can make, and even if there is a vein, what will happen is you'll tend to counterpuncture it and be able to cannulate it properly. Also, remember that when you put on sevoflurane directly to 8%, though it provides faster induction, it has a more propensity to collapse the veins. So it's very important that you maintain that balance. Start with 5% first and then gradually increase. What we also need to understand, the longer or gradual increase in percentage can increase the time that you need to take for cannulation, because if you, the child can go into spasm, right? And you do not have an IV access yet. So what is an optimal time for cannulation if you're doing an IV induction? So this is just what is available and also what I have experienced in my practice. That if you have a gas monitoring, you can look at SIVO concentration percent. If the end tidal SIVO has reached 2%, most of the times the child will not move when you prick the child. Now, if you do not have end tidal SIVO, then you could go time-based. And if you're using only sevoflurane oxygen as a mixture, it could take more than 3 minutes to achieve that depth after the loss of eyelash reflex in a child. If you are adding nitrous oxide to it, maybe you've given some oral pre-medication to the child, then this time gets reduced to 2 minutes. If you've given Dexmed, and the reason I mentioned is that I know many have started using Dexmed as a pre-medication in children, then this further reduces to around 1.5 minutes. But remember to give sufficient time so that when you puncture, the child doesn't go into spasm. Right. But important point also here I wanted to say is that this time could actually be lesser if the child is sicker, but a sicker child definitely has an IV access, so not very relevant here. Now, another important point, which is very simple, is the way you hold the hand, the way you are doing it. Are you standing? Are you sitting? the blood flow through gravity, if the hand is falling downwards, if you're sitting, temperament really matters. The chance of success increases. Also, there are many veins that require the love and attention. For example, when I lifted this hand, the vein wasn't really visible. But look at the way I'm holding it. I'm giving it like squeeze, release, squeeze. I'm not holding it continuously. Because in children, what happens is if you hold it continuously and you're pushing more than probably the arterial flow that allows into the limb, your vein is not going to get prominent. I like to perform the squeeze, stop action. And then, of course, rubbing alcohol swab is useful. And if the child is very cold, particularly in the hand will also be useful. Now, I was mentioning about the tourniquet. Be very careful if you're using tourniquet in children, because if the tourniquet is, you may never get the vein dilated because the arterial blood flow is going to be occluded to the vessel. So one way to do it is, if someone is holding or you've applied a tourniquet, feel the pulse nice and bounding, it is appropriate. If you're feeling it feeble, you have to loosen it. Also, instead of tourniquet, for younger children, infants, and sometimes even neonates, your index finger itself can become the tourniquet. So this is how you need to wrap the index finger around the hand, and the thumb offers the second support. The thumb also allows the skin to be stretched. And this is the way you're going to hold the hand before you cannulate. Now, we often use 24 gauge or 26 gauge cannulas for younger children, infants, as well as neonates. But we need to remember that there's amount of needle that protrude outside the catheter. And that actually, we have to ensure that the needle as well as catheter enters the vein before we start pushing the catheter inside. Sometimes the skin, if it is thick, it will shear the cannula before it enters. So what I prefer doing is to give a nick. So as you can see in this video, I'm using the cannula, I give a nick so that the skin is opened, and then I am using it again to enter. Because if you do it just one time, then the skin might get held, the catheter might get held in levels. Give a nick and then enter. And as you saw, the index finger can be used to occlude the vein while you remove the stilling and push the saline in there. Now, I think the best thing that has happened with the mobiles coming in, and particularly children getting addicted, is that a lot of times we are able to put cannulas without the child realizing at all. So it's an extremely useful technique, and I'm sure even you have used it with the child's most favorite videos being played while you're securing an IV cannula. There's also another device that's available on Amazon, and that's called the Buzzy. It creates vibration so that the pain sensation with cannulation is significantly reduced. Traditionally, we've used local anesthetic creams to apply to reduce the pain. But remember the duration that you need to wait. And this could be as long as 45 minutes. Or I have noticed that sometimes if you're using the Prilox, which is the prilocaine combination of local anesthetic cream, it induces vasoconstriction. So a vein that looked probably doable can actually become vasoconstricted. So we've actually stopped using local anesthetic creams in our practice because of this side effect. It's very, very important that we know the anatomy of the veins, the way they run, the venous plexus, dorsal venous plexus, both on the hand as well as the legs, so that some of these veins can become life saviors. So as you can see on the leg, or probably even this, the one that runs over the thumb. However, let me tell you that they can just be something that you begin, fill up the patient, and then transition onto something more stable. Putting IV lines on joints and at such peripheral locations, particularly on the leg, is not recommended, because if you put a peripheral venous cannula on a leg for a longer duration, it is going to increase the risk of DVT. So that should be avoided. Now, talking about devices, infrared devices are extensively available in the market. And you can see these red light emitting devices that are there. But in literature, as well as in my practice, I feel they are not very useful. And the reason I feel is that, one, they can identify really only very superficial veins. So if you really make a good tap and you try and make them more prominent, you might be able to pick them up, and you may not really need the red light device. Also, the accuracy can sometimes just be 0.25 mm, which means it can be slightly this side or that side to what you can see. Though it's found to be helpful for dark skin, I feel there are a lot of artifacts. Like here, there is some depression, and that has got picked up like a vein. So there is no vein here, okay? There is no vein, but there is a depression, and it can falsely be seen as a vein. So I think these devices are not very useful. Something that I have found more useful than these devices is this app. So this is a Vein Scanner Pro app that is available on a phone. It's available both on iPhone as well as Android version. Let me say that I have no financial interest in this app, but when you put the flashlight with this app on, it looks something like this. So this is my phone. This is the way I'm holding the hand. And look at the difference between here and here. So it helps identify veins by the same principle, probably, that the red light filter is used. And so I feel these are slightly better than the red light devices that are available. But my personal favorite is transillumination. And we have this device, it is called as the Otica. It's available on Amazon, probably for 1,500 or 1,800 rupees, but it significantly helps highlight the vein. So you can see this hand and the way it has got transilluminated. You can also identify that probably there was some vein punctured earlier for this child. So this part of the vein is not well developed. It not just allows you to look at the vein, it also helps you assess filling, which means if you use the Harvey's technique, 2-finger test, you spread it across and release, you will know whether this vein is thrombosed or whether this vein is allowing filling, patency. Okay, so I think that also is allowed by transillumination. Now, the only disadvantage with transillumination, I feel, is that assessing the depth is a challenge. You can see where the vein runs with pretty precision, but the vein could be deeper or maybe superficial, and it may be difficult to identify that. So I have a video here to show, and as you can see, I can see a vein, I am entering there, but I did require to change the depth a bit before I could enter the vein. So assessing the depth can be a little difficult. You may have to try it gradually in different planes to get your depth correct. This is one trick that I use whenever someone is hypovolemic. What happens when there isn't enough blood filled in the vein is that even when you're correctly positioned in the vein, there may not be adequate backflow. So one way to avoid that is to fill in some saline in the hub. And drop into the hub. It actually reduces the surface tension. The moment you enter the vein, you will start getting backflow through the hub. And this is, I feel, a useful technique, especially when the patient is hypovolemic. But I'm sure all of you will agree, ultrasound has been a game changer. And with more and more ultrasounds being available at more and more hospitals, every time I meet someone, whether it is a second or a third, even in hospitals, I know government hospitals in Hyderabad also have ultrasounds. So I think it's a very, very useful uh, device. However, it requires some good practice if you're going to use it for a peripheral venous cannulation. So let me just take you through what are the important aspects. We are often more used to using an ultrasound machine for doing a block. But whenever we use ultrasound machine for a block, most of the time we'll use an in-plane approach, which means that the needle runs parallel to the surface such that we are able to see the entire length of needle. But most of the time, when we are doing using the ultrasound for vascular access, it is out of plane. So what happens is, at a point of time, you're able to see only one point. And this is actually what needs precision. It requires the coordination of your right hand that is moving the needle, of your left hand that moves the probe to and fro to catch that point. And that's what I'll try and explain in the next couple of slides. So as you can see, fanning of the ultrasound, moving front and behind is important as this needle is advanced, so that we are able to capture the needle tip exactly the way it moves into the vessel. It is also called as the vanishing target sign, which means at one point you are able to see the tip as a bright white spot. And then you move the ultrasound away and it disappears. So it is vanished. Then you move the needle ahead so that you again you get to see this bright spot. So it is the target sign again. So it's shuttling between these two that will help you keep the track of the needle tip in the vein. And I'll show you a few examples. Now, I'm going to show you a video of ultrasound guided cannulation. Please remember that hand hygiene is extremely important. Also, it is important that you not just clean the skin with chlorhexidine, but you also clean the probe with chlorhexidine, because the cannula tip and the probe can be very close to each other. And you can use sterile saline as an interface instead of using jelly when you're cannulating the vessels. I also like to measure the dimension of the vein. So any vein you select, you measure the dimension. And based on the dimension, you're going to select the gauge of the cannula. And these are some of the cannula gauges and their outer dimensions that I have mentioned. And you should try and avoid having a cannula that is more than thirds in the vein. Because if your cannula occupies more than 2/3 of the vein, it will not last longer. Also, the blood flow gets completely occluded. So there is more chance of stasis. So remember, 2/3 it should occupy in the vein and not more than that. Now, just to give you an example, we had a very chubby child, and there was a lot of difficulty in finding veins. So I decided to use ultrasound, and there was a vein, but look at the depth. It's like almost close to a centimeter deep. And we kept giving some Glucon-D for this child so that we could get the child to cooperate while we are doing the procedure. And here you can see the cannula coming in, and now it is just entering the vein. As you can see, the bright spot inside this vein. And then as I'm moving it, I'm actually doing the vanishing target sign very closely. And then once I feel that at least half a centimeter or more is entered. See, this child is so hypovolemic. There was hardly any backflow. I had to fill up the hub again with saline so that I could flush it. So this was just a video to show you how in a very difficult peripheral venous access in a child, you can do an ultrasound guided cannulation. One more favorite vein that I have is the external jugular vein. most of the veins over the hands or the legs may not be good, but external jugular vein often stays by your side, particularly if you've forgotten to take a little wider bore access and it starts bleeding, then external jugular vein is right there close to you so that you can quickly secure it. There are some rules though. Always bend your cannula. Always bend your cannula before you do this access, because it runs very close, flush to the skin. And if you do not bend the cannula, you are likely to counterpuncture. So bend the cannula. The moment you enter the vein, lift the skin and the vein as you advance it, and then it will help you successfully cannulate the external jugular vein. Also, if the patient is awake, you can ask for a Walser maneuver. It helps further distend the external jugular vein. Again, elderly patients are another group where the vein may be very nicely seen, but every time you puncture it, it will blow out, because the veins in elderly patients are extremely fragile. So, one, when you're making it prominent, do not rub the skin very hard. Do not make it too prominent. Do not tie the tourniquet very tight, because if the venous pressure in the vein increases, or if the vein becomes too engorged, the moment you hit, your needle hits, even before you've entered the catheter inside the vein, it's going to start blowing out. Okay? So these are some of the tips. Remember to stretch the skin well. Sometimes these veins can roll and your cannula can move on the either side. So fix the vein, stretch the skin, fix by just touching the vein, and then push it quickly inside. Okay? So that's how you do it. Some more tips from my kitty. I feel applying this reverse tourniquet, you see that I'm actually trying to pull blood that is pooled in the entire arm. And this can be particularly helpful for ICU patients who are lying for some time and who may have some edema. So I'm applying a reverse tourniquet so that there is some blood collected in the distal part so that I'm able to find some vein. One more thing. If yourself or someone else has already tried a cannula, but they haven't got it because the vein slipped, do not remove that cannula at that point of time. Leave that cannula in place and try the vein again, provided the vein is not punctured, at another site with another cannula. And the reason is, one, if you pull out the cannula, it will start bleeding from there. And you may have to, keep holding it for a much longer time before you can try and access that vein. Second thing is, a cannula that is close to the vein actually helps stabilize the vein. So the puncture with the second cannula, if you leave this first cannula in place, will be much more successful, is what is in my practice. Okay, now I have a question. Is it okay to take peripheral venous access in a paralyzed arm? Well, I'm not really going to wait. Might get missed. But the current consensus says that it can be used, but it should be monitored closely until a suitable access is secured. So this is what the recent literature says. Now, another important question, particularly because patients do undergo breast surgeries, axillary dissections. Is it okay to take a peripheral venous access on the side of breast surgery after the surgery has been done for that patient? Well, typically, while learning, I was taught that we should not do cannulation on the side that axillary dissection has been performed. However, recent evidence shows that ipsilateral arm can be used for short duration cannulation. Another thing, there are many patients who have been told that do not get blood, do not use NIDP on that side, because there is a risk of lymphedema. But recent literature says that NIBP measurement can be done, and even IV cannulation can be done for short duration if required, provided there is no lymphedema on that hand. One. Second, more and more surgeries these days are sentinel node biopsies. So the incidence of complete axillary dissection has come down. So with more and more sentinel node biopsies, the concern of developing lymphedema has significantly come down. So if a patient does not have a lymphedema 1 year after sentinel node biopsy on the same side, or 3 years after axillary lymph node dissection, then it is safe to put a peripheral access on that side. Okay. Remember that whenever you are cannulating the ipsilateral side, maintain all aseptic precautions and use the shortest duration that is recommended, which means within 24 hours. Beyond that, you should not vein. Okay. Now, we've talked a lot about peripheral venous access. However, there are other accesses and devices that we as anesthesiologists need to be aware of. And now I'm going to take you through something that's called the midline catheters or midline devices, which are also peripheral venous access. And then move on to central venous access, talk about the PICC lines, the standard central lines, which are non-tunneled ones. We'll also talk about the tunneled central lines, which is the Hickman catheter, and implantable port, which is typically seen in patients who require very long duration of vascular access, like for cancer patients. And then quickly touch upon intraosseous access before we close on for today. Now, let's talk about midlines, and there's also something that's called as the mini midline. So let us see what they are. Now, if the venous access is difficult and you think that a little longer duration access may be required, say maybe 1 week, 10 days, but you may not get veins again and again for a patient, you may have to opt for midlines. Sorry. So midlines are typically put in the deeper veins of the arm. And when it comes to forearm, we call them mini midlines. So if we talk about the deeper veins of the arm, there is a basilic vein on the medial side, and there are brachial veins along the brachial tree, and there's also a cephalic vein on the lateral side. So whenever you put a line in these deep, any one of these deep arm vein, and the tip of the catheter is in the central position, you call it a PICC catheter, that is peripherally inserted central catheter. But if you put a longer line in this vein, something that does not reach the central location, it is called as the midline. So needless to say, the PICC lines are longer than midlines. PICC lines also last longer as compared to midlines. So here is a midline that I will show a video. We typically, like this child was a child who's undergone neurosurgery and was tracheostomized, required antibiotics for a little longer duration. So midlines are typically used whenever you need to give antibiotics, antifungals, which are typically required for 2 to 3 weeks or sometimes even 4 weeks. If some patient has osteomyelitis, you would want to give antibiotic for 4 to 6 weeks. So these are typically the indications of midlines. So as you can see, I'm using an ultrasound to screen for the deep veins. And here is the brachial artery that I have highlighted through the Doppler, and just next to it is the brachial vein. So this is a midline that I'm going to use. And as you can see, I've given some local anesthetic after identifying the vein. And here you can see the needle coming in as I'm tracing the tip. And this is the vein where I'm targeting. So it has come and it has entered the vein. The moment it has entered, we reduce the angle of the needle and push in the guide wire. I always like to confirm that the guide wire, as you can see coming down here, is correctly located in the vein. See, this is the vein and this is the bright guide wire. So the position is correct. And then the needle itself is used to make a small nick. A dilator is used so that the insertion of the catheter is easy. And this is how, once we put it, we check the flow and we fix it. For this case, we have done a C-arm, but that's not really required. This is how we would fix it. This fixation is actually a sutureless fixation. Okay, so it's just a clip. We put the two wings, the holes are there in the wings. We put it in the clip and we fix it like this. It's also important to label it as midline because it can get confused with a PICC line unless you have documented it in a chest X-ray and labeled it, of course. Now, talking about mini midlines. Now, mini midlines, as I said, are something that you would put in the forearm veins, and typical veins are the cephalic and the basilic veins. Sometimes the midline vein of the forearm also can be used, and these are long peripheral IVCs. So Helmier is one company that produces it, and it is something that looks like this. Because it is long, they have given an extra flange here so that we can hold and grip it comfortably. Otherwise, putting something with a very long, we may not get that precision while we are inserting. So that's the reason why it is given. And midlines typically would last for about 1 to 2 weeks. And often we prefer cephalic vein in the forearm to put this, and you should avoid putting it on the joints. So I have a video here to show you how we are putting the mini midline. So this is the long PIVC. As you can see, there are 2 flanges. One flange is here and one flange is here. And I'm holding this flange and here as I'm doing an guided. You need not do ultrasound guided if the vein is very nicely visible, but this is what I'm doing. So I've identified the cephalic vein, and as it moves, look at the way I have pulled the flange ahead and then pulled out the stillet. Okay, so this is how it needs to be moved. The moment it enters, there is a holder which is there, the pink color, and we use it to pull, like push it aside. So unlike normally where we insert the cannula together, this technique is slightly different. And I always like to counter check the length at which it is placed inside, and also label it as long PIVC so that people don't consider that it's just a regular cannula, because it does look like a regular cannula from outside, and they should know that they have to handle it more carefully. Now, I told you about different lines, the other devices. As I said, peripheral line, usually it doesn't last beyond 3 to 5 days because the length of the cannula is small. It tends to develop thrombophlebitis earlier, whereas midline catheter, because it is longer, it lasts for about 1 to 2 weeks. Mini midline also lasts for about 7 to 10 days. The regular central line can last, if it's antibiotic coated, it can probably last for about 3 weeks. But most of the time, if it is not antibiotic coated, it could be just probably around 2 weeks. PICC lines are meant, though I've written more than 1 week, it depends on the indication, but it usually lasts for 3 months, 6 months. We've also had patients who've retained their PICC lines for around 2 years. Hickman is something that lasts longer, but it is wide bore. So there is slight difference between the indications for PICC line and Hickman catheter. An implanted port is a device that can stay in the body for years. Now, which device to use depends on what type of medication is going to be required. So certain characteristics of the medication that we all need to know when selecting whether a peripheral access is required or central access is required are the pH. Any extremes in pH, you have to go to select central venous access. Hyperosmolar solution, hypo or hypertonic solutions. Any solution for nutrition where the percentage of dextrose is more, 10% or more, or the drug is irritant or vesicle, you should use a central venous access. Now let's talk about central venous access. There are three most common sites: the internal jugular, subclavian, and the femoral vein. This table I've put up mainly for the residents. But the choice actually depends based on screening and the availability of ultrasound. If with ultrasound available, internal jugular has become extremely popular. Subclavian can also be accessed using difficult. It requires a little more training, but in terms of comfort for the patient, particularly if it's going to stay for a longer time, subclavian vein is much more comfortable. It is associated with the least risk of infection as well as thrombosis. And femoral vein is something that's not commonly done unless it's done in an emergency or because of some reason the upper body ultrasound is multifactorial. It's not just useful to identify the vein, but used as a real-time puncture and at multiples of once you've pushed in the guide wire, use the ultrasound to again confirm that the guide wire is in correct position. After you've pushed the catheter, again use the ultrasound to verify that the catheter is in place. It can also be useful to identify the tip of the line, and we'll talk about it in a minute, and also identify the complications, meaning whether there has been a hematoma or there has been pneumothorax, can be identified ultrasound. Now, this is the technique that I described, RASIVA screening, which is a 7-step approach to do screening before you decide and where to puncture. At what level, if you're using IJV, or places are also included in this, and you're going to select the most appropriate puncture site. Now, before we talk about central venous access, it is important, especially for the postgraduate student, artery from the vein. And this can be identified by completely. So if you're compressing, as you can see, the vein gets collapsed. The artery may not. However, if it's a child, if you apply too much of pressure, you can also compress an artery. So remember that this is a test. You can throw in some color Doppler and you will see that Doppler in an artery is more pulsatile as compared to vein. And I have this video to show you. This is actually a subclavian artery and vein where completely not able to identify much. Then we put in some color Doppler. So both looked pretty similar. So we used a pulse Doppler, look at the waveforms that are generated, and you can make out the difference. This is a vein because the waves are of lesser amplitude as compared to the artery. And this is something that can be more sure shot as compared to the other techniques. Now, how many times that you have tried to do an internal jugular vein access have you actually looked at the artery? If you've not, the next time you're going to do it, please have a look. And this is because while we do a IJV access right behind the artery is there, and we have to identify where it is, how it is running before you decide to do the puncture. Because so many times it will be closer and it is at risk of counter puncture when remember to look at the vertebral artery. In a video I wanted to show you because this is a child who has an IJV thrombus. So this is how you identify. Can you see this bright echoic structure inside the vein? So this is an IJV. So obviously we cannot cannulate this vein and we'll have to select some other vein. So especially patients who've undergone repeated cannulations or those who are at thrombosis, venous thrombus that can be identified and should be identified before you do the puncture. Okay, I think I've told you about the in-plane, out-of-plane access, but with specific to the central venous access, IV, as I mentioned earlier, a short axis technique is preferred. So short axis, you can see the IJV like this, you can see the carotid artery on one side, you can see the vertebral artery posteriorly. But the needle that you are putting in will not be seen as one continuous. It will just be one of hyperechoic structure that you see as a needle. So this is the disadvantage with short axis. If you're using long axis, wherein the probe is put vertically over the entire length of the vein, you are able to see the entire length of the needle, but you are able to see the artery, and that is the disadvantage. There is something that's described as oblique axis that you can use, wherein you will be able to see the length of the needle as well as the other structures, and I have a video for you to show. So this is the short axis, and then we turn it obliquely so that now the IJV has become longer and the carotid is also seen. And this is how we've done the puncture. The whole length of needle is also seen. So this is how you do a oblique axis puncture for the IJV. Now, I told you earlier that ultrasound helps us in tip location. Now, what's the ideal tip? It is the cavo-atrial junction between the superior vena cava to the right atrium is the ideal tip position. Many a times we say up to 2 or 3 centimeters below the level of carina. So level of below the level of carina as identified on chest X-ray. But chest X-ray is always done after the procedure, is it not? So we'll talk about how can we make sure that the central line tip is in appropriate position. If you're doing it in an adult on the right side, 13 centimeter. If the patient is tall, then 15 centimeters. And add 2 more centimeters if you're doing a left side vein. Okay. If not, you can actually measure the length, and in there is something that's called as the Perry's formula, wherein height in centimeters can be divided by 10, and that is what roughly length that needs to be pushed inside. Okay. That happened to that you've put an IJV and it's moved into the subclavian vein. Yes, it has happened sometimes, right? Is it possible to have an ultrasound guidance to make that this never happens? Yes. And this is, once you've made the puncture, you have to slide the ultrasound probe till the root of the towards the foot so that you are able to get this view. Now, this is a view wherein the IJV has, and it's the view at the Pirogov confluence is what they say, where the IJV subclavian from the side merge become the brachiocephalic. And here, if you see the catheter or the guide wire moving towards subclavian, then it is not correct placement. You should be able to see it moving downwards towards the brachiocephalic. And we have actually detailed all this technique in one of our in 2019. So you can probably just have a look at this. And if you use this technique with an ultrasound guidance, you will never misplace the central line direction. Now, I spoke of knowing exactly, are we able to predict if it lies at the SVC-RA junction? And one of the ways we can do it is by doing ECG guidance, which is intracavitary ECG. So let's assume that the tip of the central line, for some reason or with some technique, was able to capture ECG. How would that ECG look? As this tip moves closer to the SA node, which is roughly at the SVC-RA junction, the P wave is going to become taller. And once it crosses the SA node, there is going to be initial negative deflection of the wave. And this principle you can use to place the CVC tip correctly. And I'm going to show you a video of how we do it. So this is a device that is required for intracavitary ECG guidance, which is available with, I think the Telefix has, the central lines have this disposable white tubing, and this is that you need to have. I mean, we have it, we had got it long back. So this is how we do it. So if you see, we have connected this guide wire and to the ECG cable adapter, and as we are pushing it in, P wave is becoming taller, right? Once it has gone to a significant distance, now if we push it more inside, can you see this negative deflection that has started coming? So negative deflection means we have crossed the SA node. So we'll have to pull it back again slightly. So this is how you use intracavitary ECG guidance for the central line tip adjustment. Technique that you can use, which is the echo guided. So someone else is to do echo. So there's an apical view that is being done, and you can see the air bubbles entering. And they say this is called as the rapid atrial swirl sign. And if you see it in 2 seconds, then you are in correct. However, we are not very fond of this technique. What we found more useful is something that I'm going to now. This is an echo guided technique wherein you have to use a subcostal bicable view. I'll show you what it is. But in this view, you'll actually be able to see the guide wire coming into from CVC into the RA. So let us see this video. So it is freeze turner. And as I'm changing, you're able to see, okay, I'm going to pause this here a bit. You're able to see on the ultrasound screen. What you're able to see is this view. So you can see the IVC. So this is the typical IVC hip view that we take to look at IVC collapsibility, but we tilt slightly headwards so that we are also able to capture the RA in the same view. And somewhere here we get to see the SVC. So as I continue the video, please focus on the RA and please focus on what is coming through the SVC. You will see a guide wire that comes into the SVC first, and then gradually as I pull the guide wire, you will see the guide wire coming, and then I leave it up to here, and that's our correct position. So here it is. Now we'll go back to this is the IVC, this is your RA, and can you see this guide wire coming in? Yeah, so the guide wire was coming in. Now I've started pulling the guide wire outside. See, now you can see this bright hyperechoic guide wire that's coming. And this is the SVC RA. So I want to just, and that's the perfect location. So this is something that we found relatively more useful and precise. Now, we are going to move on to subclavian vein cannulation, which can be done infraclavicular or supraclavicular approach. This is a quick video to show you the infraclavicular subclavian. So this is the clavicle, this is the short axis. You could see the cephalic vein that came in to join the subclavian vein. This is the subclavian artery, and the needle coming in till it enters the vein. We can see it as a hyperechoic spot, and this is how it got cannulated. Similarly, a supraclavicular subclavian can be accessed in long axis. So here is a long axis view. Here is the external jugular vein that's joining in, and you can see the needle that is entering, and it's almost, rather than supraclavicular subclavian, it's entering into the brachiocephalic. And this is how you cannulate a supraclavicular subclavian or a brachiocephalic puncture. But remember, whenever you've approached a subclavian and you fixed it typically the way you fix a subclavian catheter, it can kink when the patient is turned in lateral position. So if the patient is requiring lateral position, either for surgery or may require lateral position in an ICU, then it's always better that you fix the catheter posteriorly. There is no kinking, as you can see in these images. We often in cancer hospital have to cannulate central veins where the counts are low. And whenever the platelet counts are low, there's likelihood that it can keep oozing from the site. So what we found very useful is this. It's called as True Seal. It's a wound closure device. And putting, just sealing the entry spot, as well as if we've taken sutures, the suture spot, then it helps reduce bleeding from that spot, even if the platelet count is low. I want to talk a little more about opportunity to read these advanced lines, and hence I'm going to be very crisp in what you need to know about these lines. As I mentioned earlier, that PICC line is a peripherally inserted central catheter from the deep veins of the arm towards location. Traditional PICC lines were these. When I was training, we used to use cava fixes, but this is an older generation. And there are some disadvantages with this. And the first and the most important is that the vein has to be adequate size and visible and palpable, at least, for you to use it. The puncture usually used to be around the elbow. So it increases the risk of thrombosis as well as infection for these PICC lines, and hence keeping these PICC lines probably just for a couple of weeks was what was possible, whereas the newer PICCs, which are ultrasound guided placement, can be kept for months and sometimes even a year, as I said. There's a specific screening that's called as the RAPIVA screening that has been described at different locations for you to look at the veins before you decide again which vein are you going to cannulate and at what location for PICC line insertion. The vein typically selected should be occupying only 1/3. Venous access, I said that it should not occupy more than 2/3, whereas here it should not occupy more than 1/3, because this is a deeper vein and a little bigger vein. So we have to make sure that there is adequate blood flow that is allowed. Otherwise, there is a risk of thrombosis in these veins. Depth of the vein should not be less than 2 centimeters, and it should lie in the center of the arm. Now, this is a picture that shows the axilla on this side and the elbow on this side. So it is something that we call as Dawson's zone, and the green zone is in the mid, which is the appropriate for puncturing the for the PICC line. Now, I have a quick video for you to show the PICC line insertion. So this is the middle 1/3 of the arm. Ultrasound guided is doing for a brachial vein, and once that is done, we put in the guide. Once the guide wire is in place, now here we are just confirming that the direction and the length is correct, because once we know the length is correct, then we are going to cut the PICC line. This is a dilator sheath that needs to be put in before the PICC line goes in. We remove the dilator, and through the sheath, we are now pushing in the PICC line. So this is how PICC line is placed. The sheath is torn off, the guide wire is taken off, and then checking the backflow and fixation. This is how we sometimes use chlorhexidine gel patches, which help reduce the infection for these lines. And this is a post-procedural X-ray showing the correct tip location of the PICC line. We're now going to move to tunneled central venous catheters, and which is the Hickman catheter. So what's peculiar about these catheters is that they have a special Dacron cuff, as you can see here. And this Dacron cuff, because we subcutaneously tunnel these lines, this Dacron cuff that lies in the tunnel is going to cause fibrosis of this tunnel. And this is how it reduces the risk of infection for these lines. And we can keep it for a couple months up to a year. These devices are very wide gauged, it's like a 12 French catheter that goes in an adult. In children, smaller French sizes are available. So for human can be used, little older child can be 7 French, and a teenager can take 9 French. Whereas, as I said, in adults, we use 12 French and a double lumen Hickman catheter. So this is a quick video to show Hickman catheter placement. This is done, and a guide wire is placed IJV. You can see now we are tunneling it subcutaneously from an exit point on the chest. And that is the tunneler rod. So once it is tunneled, the rod goes in, we tie the Hickman catheter and pull it up. See, did you see that cuff, Dacron cuff that went in? Yeah, so this is the location of the Dacron cuff now. Now, we've put in the dilator sheath in the IJV. We are measuring the required length, and now we are going to pass this catheter through the sheath in the IJV into the IJV. And once it goes completely inside, we are going to push it in. We are going to verify the position on C-arm. We have made sure that all the loops are smooth. There is no kinking anywhere. And then this is how we fix the Hickman catheter. This is how the Hickman catheter is going to look on an X-ray. This is, however, a subclavian placed Hickman catheter. And this is one explanted single lumen. A single lumen catheter that we put in children, as I said, 4 French, is called a Groviac catheter. Now, the last part, which is implanted ports. This is how it looks like. It has a port body, a connector, and a catheter. And once it sits inside the body, the needle puncture is done through the skin subcutaneous tissue to enter this port body. So this picture I have taken to show you how the silicon septum, which sits here, I've actually broken this port so that you're able to see the needle that passes beyond the silicon septum into this cavity. And here is where the catheter is connected. You need special needles, they are called as the Huber needles, to access these ports. The implanted port placement in my hospital is done by us anesthesiologists, and that's the reason why I am showing you this video. But most hospitals, most centers, it is done by the surgeons. So I think it is very similar to the Hickman catheter, except that a subcutaneous pocket is made. As you can see, we have made a port pocket, and again the railroading is done, and we are bringing the catheter into the pocket. The port pocket is where the port body is going to lie, and after checking the correct position and making sure that there are no kinks, we trim the catheter. After trimming, we connect it to the port, and then we tuck in the port inside the port pocket, and then this is how it looks in C-arm, and then we are going to close the wound. This is how it looks on a chest X-ray, and this is how it looks after it has healed completely. I just wanted to show you how to access a port, because it is likely that you get a patient who has a port and you should know how to use it. You should feel confident about using it. So this is how you're going to use the special needle, which is the Huber needle. I call it a 3-point fixation. I've used 3 fingers to stabilize the port, while the index and the thumb finger is used to push the needle inside the silicon septum. And then check that there is backflow. If there is no backflow, please do not use the port, okay? Because it's likely that the port needle is not in position, and then there can be problem. Look at the way I'm flushing it. It's push, stop, push, stop. You have to flush. This is the special technique that's required to flush whenever you're using a port. And now I have a video to show you the removal of the needle. Once you have given whatever is required, stabilize the port with 2 fingers of one hand and pull out the needle like this. So just to show you how to access and deaccess the port. Now, if you do not have a Huber needle, is it okay to use the port? Well, no. And the reason is, if you use a normal needle, it can actually damage the silicone septum. The Huber needle, like this, is atraumatic. It makes a very tiny hole when it enters, whereas when you use a normal needle, it can actually tear away the septum. So unless it's a life-saving indication, there's no venous access and you're wanting to give adrenaline, do not use normal needles, use only a Huber needle. Now, while I summarize all the devices that I have shown you, I feel what really matters is knowing what is available with you and be able to use it properly. It's often good to keep it simple. It's good to know as knowledge, maybe even for exams for postgraduate students. But when it comes to practice, I think this vortex approach is extremely useful, which means that you start with a standard peripheral IV access. If you're not able to do it and you have an ultrasound, go ahead and use ultrasound for placement, provided you've trained yourself in using it. I ask my fellows to do ultrasound guided peripheral line access practice after the patient is under general anesthesia, so that they can take their own time and they build confidence so that they're able to do it whenever they require to do it awake. If you still do not get a good peripheral vein, then you can go ahead and choose central venous cannulation. So each one of us should be very good with these three things, and that will sort out literally 95% of the situations, if not more. And as a vortex approach, if situation demands, we should also be able to do the intraosseous access. So I think these are the four things that I would want each one of you to focus on and learn and be expert at. So to close, I thought I'll just finish off the intraosseous access. It is a life-saving technique. Each one of us to do it. So these are various areas: the distal tibia, the distal femur, and the proximal humerus. Of course, sternal punctures have also been done in adults for intraosseous access. You may not have all these intraosseous needles, but what we have done in our crash carts across hospital is that we've put sternal puncture needles. And these are the ones that, in an emergency, we use as intraosseous needles. I have a quick video for you to show how intraosseous access can be done. I think the voice may not be, you may not be able to hear the voice, but I'm just trying to show how we can do it. Okay. So this is just a mannequin that I'm going to use to demonstrate. And this is the proximal tibia that I'm going to choose for doing it. As I said, it can be a distal femur or a distal tibia that can be used. So here I've used an official needle, and it comes in different sizes. So if you have a typical intraosseous needle, you can use it, or sternal puncture needles like I showed. I think, let me just take you back to quickly on, So I think what is important is it needs to be about a finger's breadth, medial as well as inferior. And you make sure that you support the needle, wear a sterile glove, quickly clean the area. And local anesthetic can be used if situation demands. Direct it slightly inferiorly so that it stays away from the epiphysis. Whenever it's going to stand by itself without support. You have to remove the stellate and you're going to aspirate. And there could be some marrow, like thickened blood that comes in, and make sure that whenever you are flushing, there should not be any local swelling here, which means that it is in correct position. Now, just one last thing I wanted to mention, and that is, can contrast be injected in IO line? And this is very, very important because maybe there's a case that's come with trauma, you haven't had access, so you've put in an intraosseous line, and now this patient needs to go in for a CT. And there has been literature to say that yes, you can use IO line for contrast injection. And this, I'm going to sum it up by saying that we are the experts in vascular access, and it is our responsibility to make sure that we learn various types of vascular access and are able to use them appropriately. Also set up teams, involve the nurses, technicians at critical areas, especially ICUs, ERs. Also in the pre-op holding area, the nurses are trained so that, if someone faces difficult venous access, these are the locations where they know that they need to refer the patient so that we can place with a technique. With this, thank you so much for patient listening. I know the audience has been very diverse, different levels, probably I feel, right from graduate experts and seniors, faculty. I hope that each one has had their respective take home from this talk. There are a few articles that I have contributed to and that can be used for further reading for those who are interested. Also, recently we have compiled this How I Do It ISA video monographs, and the access section there is extremely helpful. I also want to say that in the upcoming Coimbatore, we are doing a special mass on venous access. We are going to have mannequins there, hands-on experience. So those who are interested in learning midlines and PICs, you could join us there. Thank you so much for patient listening. And this is my department, my team, without whom I would not have been able to achieve this. Thank you. It's pretty heartening to see so many people logged in. I think at a point of time, I also saw some 80 members.
80
so
members,
thank you.
yes,
80 members. I remember 81 is what I saw. So thank you so much, everyone, for logging in. If you have any questions, I'm more than happy to answer. And I would really like seniors sharing their experiences on how they handle difficult venous access. I think Vijayakant sir is saying something, but he's muted. You need to unmute yourself, sir.
Vijayakant sir, please unmute yourself.
Yeah. Good evening, madam. Am I audible?
Good evening. Yes.
Yeah, it's excellent lecture, madam. No doubt. So you covered from basics to all advanced, how to place a tourniquet, how to dilate a vein. From all those aspects to advanced techniques, definitely we learned a lot from you. And my thing is, we are definitely venous experts, anesthesiologists. But I hope someday we will reach your expertise so that we can also do these things. So my experience is like I share so many areas of interest with you, like pediatric anesthesia and cleft anesthesia. So practicing since more than 23 years. So my experience, I have a doubt. The thing is, we long back we had one pediatric case, few months maybe for craniotomy. So it is a difficult IV access. Finally, I got a peripheral vein and saphenous vein. So we started the case, but case is under the drapes. Total baby is covered under the drapes. But after some time, we observed hypotension due to bleeding with that. But after maybe 2 3 hours, finally we observed the swelling in the lower limb. So fluids we are giving through syringe pump. So if it is normal IV fluid, gravity dependent, usually that stops when it is not in intravascular place. But syringe pumps, they push wherever is the cannula is. So how do you
So right,
monitor?
sir.
How do you monitor these small tiny babies under the drapes, whether that vascular access is intact or not? That is one question. The same baby, we had that experience. Baby collapsed. After that, we saved with an intraocular cannula,
Amazing.
epidural needle.
Amazing.
We put through an
Excellent.
epidural needle, and after some infusion, we got a line, and finally we could save the baby. So after that, I bought even that intraosseous kit that was worth around 25 to 30,000 at that time.
Yeah.
But fortunately, I need not use that kit. So ultrasound came into use after that. Maybe I got exposed to ultrasound after so many years. So my doubt is this: so how do you monitor a vascular access site in a small babies covered under drape?
Sure. So if you have ultrasound, I think the best way is to actually screen and make sure that the venous tip is inside. So I think that's the most short way. As you
Yeah.
rightly said, that infusion pumps can sometimes be very deceiving. They will push and sometimes extravasation can be missed. Once you have placed, just by connecting an IV bottle is important, and reversing it, you take that bottle and put it down, you sometimes will be able to see some flashback. So I think these are 2 or 3 things that in my
That is,
experience.
yeah, definitely, madam. That is when we inserted the cannula freshly to confirm the place. But I think during the process,
Oh,
these
you
syringe
should try
pumps,
and keep, yeah, you should try and keep under vision as far as possible the
yeah,
place
that is
when we
the,
have cannulated. Correct. And
uh,
any doubt, like you said, patients started hypotensing. The first thing that should come to your mind is to check the IV cannula.
and all the difficult cases, I'm starting the case after second IV cannula after complete case. So only one IV cannula. If it is difficult case, if we lose that, we may lose the
Correct.
baby also. So that's what
Correct.
I practice.
Wonderful.
Thank
Yeah,
you.
very important points. Thank you, sir. Anyone else wanted to share? I thought someone had raised the hand. Was it Ramana Prasad, sir?
Yes, madam. Good evening, madam.
Yeah, please, good evening.
Madam, can when you are in doubt in central venous cannulation, can we connect it to a transducer and see the waveform and confirm? And
Yeah.
also, can we send the sample for ABG?
Absolutely. Very so actually I didn't deal that point, that occasionally after entering the vein, by mistake, the needle tip, when we are pushing the guide wire, the needle tip can counterpuncture and enter the artery. That's what you're mentioning, right? We've had such incidents some time back. So what happens is, it is by mistake in the artery. When you put it initially in the vein, you aspirated, you knew it was vein because the blood looked dark, you disconnected, the flow was not like arterial. But when you're pushing in the guide wire, by mistake, that the needle moves ahead and enters an artery, and then the guide wire is now in the artery, and you have dilated and you have put in a central venous line inside. As you rightly said, if you are in any doubt, transducing it or sending a blood gas, or even if you connect an IV, if it's a vein, it'll flow in properly. If it's an artery, it'll start jumping behind. So that is the way that you can identify. But more importantly, I want to talk about what to do if that happens after you have identified. So literature says if it is 7 French or more in an adult that you have dilated in an artery, you have to be ready to explore if you are removing. In fact, the literature says that you should not remove it like that. You have to explore and suture off that artery. But we have removed it occasionally, and it should be a compressible site. If it is a non-compressible site, like in subclavian artery you have entered, then there is a high risk of bleeding that can keep collecting in the pleural cavity and we losing the patient. So we have to be extremely careful if by mistake we have cannulated the artery.
Madam, technically, which is easier, right subclavian or left subclavian?
Right subclavian is always preferred because it is straight, it has a shorter course towards heart. So right is preferred. Left, you can use if right has some problem. What's your experience?
One of my friend in America told left is easier technically, but preferred is right subclavian.
Yeah. No, I don't think so. I think both would be same in terms of difficulty, but preferred is right just because it has a straighter course towards the heart. Left, once you put, as I said, you need to check which direction it has gone on this side as well as this side. Also on the right side, you have to verify that it has not gone into the right subclavian. Otherwise, it might start from right IJV. It went into the left IJV. It went into the left brachiocephalic, but it entered the right subclavian. We've had such situations also. So you have to screen both on the left root of the neck as well as right root of the neck to ensure that it has gone towards the heart.
Madam, one hand is having AV fistula and another hand is edematous. What trick you will play to get a venous access?
So AV fistula hand should never be used. For the other hand, how much is the edema? If you have an ultrasound and you are able to see a vein, then we can use the edematous hand also, but make sure that your cannula is longer. So use a mini midline because the length of the cannula is longer. So even if it is edematous, a significant amount of the catheter is going to lie in the vein. You can go a little more proximal because often edema is more distally. If you go proximal, the edema will be relatively lesser. It's something like you'll have to try a midline, as I said, or central venous access, of course.
Thank you, madam. Thank you so much.
Sure, thank you.
So, Lakshmi ma'am, any more questions?
Everything is so clearly explained and in detail, Praveen. I have no doubts. I only have one experience. Madam, once when one of my postgraduates was cannulating the subclavian vein, right subclavian vein, he accidentally punctured the subclavian artery twice actually. But fortunately, we gave a lot of pressure for a prolonged period of time in the neck region itself, and we could save the patient. We didn't lose the patient, fortunately. When we learn about all the complications during the subclavian vein cannulation, arterial cannulation is one of the most dreadful complication in subclavian vein complication because we cannot put a pressure on the heart while doing it. But we were very fortunate, madam. That is one experience I had.
Just wanted to add before we move on to the second point you want to say. So there is, 2-point compression whenever a subclavian artery has been punctured. As you said, from the root of the neck, you have to press here and also infraclavicular. So 2-point puncture, 2-point pressure, if you give, then I think is the way to do it.
Yeah, that's the thing we have done, madam. And for a prolonged period of time. I took a lot of time to see to that the hemodynamics of the patient was stable and they didn't get disturbed. Because one way of assessing the internal bleed will be to monitor the hemodynamics, right?
Yeah.
So at the same time, madam, I was asking him to change the direction, but he punctured it twice, actually, which really was very dreadful. That was and most often, even in neurosurgery cases, madam, when sometimes we don't find proper peripheral vein access. I found the digital veins very good, madam, as you have shown in one of your pictures. You said you start with a digital vein.
Correct.
And you can go for after the
you fill up the patient or after induction when there's little more vasodilatation. Then you can
but madam, we can even cannulate the digital veins with an 18 gauge cannulas. Yes, madam, I have done it multiple times, not once or twice. And I'm very comfortable and confident with the digital veins actually. So when I saw the picture, I was very happy to see that somebody else also follows like the same pattern which I follow.
Yeah.
There are lots of occasions when digital veins were the only ones available, when no other peripheral veins were available in the upper arm, upper limbs. It was a very insightful
Thank you for
lecture,
sharing.
madam.
Correct. Thank you.
Madam.
Thank you. I see Dr. Rajendra Prasad also wanting to say something. Tell me.
Madam, pulling the hand will straighten the vein while cannulating the subclavian vein and makes the process easy. Is it true?
Yes. Oh, yes. Oh, yes. So I used to do that when I did not use ultrasound, whenever, the hand is like this, I believe that pulling it down, isn't it? That's what you're saying, no? Pulling that hand down.
Yes.
Yeah. I feel the way it helps is that it slightly opens up that space. So you have to keep something under the shoulder and pull the hand. It opens up that space so that you probably don't hit the clavicle. You can safely go under the clavicle. And I think it improves for some reason. I don't really know what the reason is, but it does help.
And keeping the sandbag under the shoulder blade also helps.
Yes. So where I like to keep the sandbag or that bolster is between the two scapula blades, because if you keep it under the scapula, I don't want the shoulder to turn like this, because then the subclavian vein goes deeper. I want the shoulder to fall down, So I leave it only in the center of the two scapula. If it comes too much lateral, some people put it till here. If you put it till here, this shoulder is not going to fall down. You know what I'm saying? So,
yes.
Yeah. I think Dr. Rajendra. No, I think Dr. Rajendra. You want to say something, Dr. Rajendra? You have to unmute yourself. Yeah.
We are putting 500 ml NS bottles, madam, and pulling the hand one side. Especially in obese patients, it is helping, madam. Then the thin patients, the patient is very obese and so much of subcutaneous fat is there. Sometimes it is helping, madam.
Absolutely. So it helps to open up that space and the subclavian vein becomes more superficial. Otherwise, the subclavian vein will be deeper in obese patients. No? So that's why it is useful.
Yes, madam. And madam,
thank you for sharing.
Placement of the needle, like whether most of the times in the medial or lateral, usually we will put 1 centimeter below and 1 centimeter lateral, madam.
Yes.
But in obese patients, if you are putting little medial, it's becoming easy sometimes, madam.
Correct. So I think it depends on the way subclavian vessels run more medially or laterally depends on the shoulder style, There are two types of patients who have very droopy shoulders and patients who have who are stout. So patients who are stouter, I have in my experience, the subclavian vein is much more medial as compared to lateral. But patients who are thin built and who have droopy shoulders, they will have the vessel more lateral. So you could probably use that.
Yes, that's fine. And like in obese patients, putting the needle little medial, we are getting easy when compared to putting lateral, madam.
Correct. Same. I think my experience is also the same.
Thank you, madam.
By listening to this, I got a small doubt. So
Sure.
the thing is, I think a few people are still using blind technique. So is it legal to do blind technique nowadays? So
So I feel if you don't have an ultrasound, obviously you'll do blind. But I would request each one of us to try and bring in ultrasounds in our OT, because I think that's the future, that's the tomorrow, that's what is going to add safety for us. And we have to ask for ultrasounds for our OT. And if you have an ultrasound and still don't use it, then it is not acceptable.
That's what. If you have an ultrasound in the hospital,
you should use it.
And if you don't use it, is it legally bound for us to be like
I don't think it is yet legally bound, but let me give you an example of a patient whose ICD placement caused splenic injury and the patient collapsed and died. And this case was like more than 10 years back in
Yes.
one of the hospitals in Mumbai.
Mumbai.
And they said that why did you put an ICD without checking and marking the spleen? So what I'm trying to say here is that if it's available, then it's always good that we learn how to do it and we use it for our safety, because if there is any complication, then it will be difficult in the court of law.
The same case, I have seen that. That's why I asked the same thing.
Yeah.
And I think we came a long way from looking the vein, and after that, a few years of experience feeling the vein, and now again we are looking through ultrasound. The same circle we started with looking the vein, looking at the vein, feeling the vein. Now again we look at the vein and cannulate. That's what how it evolved. Okay.
Sure. Thank you, sir.
Good evening, madam. Dr. Subramaniam from Anantapur, madam.
Good evening, sir. Thank you for joining in.
It was really a nice topic, madam, because you have covered from the very basics to the latest techniques using gadgets. And one clarification, madam, regarding actually I had to add one point. When you have doubt in differentiating whether it's arterial or venous, especially with femoral vein, because some people take the heparinase saline syringe. Instead of that, if they can take an empty syringe, of course, definitely will aspirate. And it will be easy to differentiate just by looking whether it is an arterial or venous. Because if you take the heparinase saline, it mixes with it, and the color you may not be able to differentiate.
Correct. Color becomes very bright like an artery. Even if it is vein, it will look like an artery. Correct. I agree.
Point I want to add. That's all, madam.
Yeah. Thank you. Yes, I agree. Thank you.
Thank you, ma'am.
Okay, looks like we've reached 8:30.
Thank you, ma'am, for a wonderful presentation that was with very high practical insights. I think it would be very useful to each and every postgraduate and every practicing consultant. Now I request Dr. Rajendra Prasad, our City Branch Executive Member, to present a vote of thanks.
Good evening, madam. It's very excellent presentation, madam. Not only for the postgraduate students, even for the practicing anesthesiologists, you have enlightened very well, madam. And thank you, Ramana Prasad sir, Subbulakshmi madam, and Vijayakant sir for your inputs. And thanks to all the participants for attending today's schedule. And thank you, Praveen sir, for selecting such a good topic from a apt teacher, sir. Thank you very much, sir.
Thank you. Good night, everyone. Good night.
Thank you, madam. Thank you, everyone.